Thank you for the opportunity. I will start the presentation without any delay. Bismillah ar-Rahman ar-Rahim. My topic for today is latest trend in hypertension management, what ESC 24 guidelines tells us. So it will be basically focused on what are the changes that have been made since 2018 ESC guidelines on hypertension. This guidelines that were published in 2024 had 136 recommendations, out of which 57 were the new recommendations. And these are the few categories in which recommendations have been changed. Measuring BP, definition, classification, diagnosis, preventing and treating, management of specific patient groups, and patient-centered care. What was the reason to bring about the new guidelines? This was the reason, as hypertension is the leading cause of morbidity and mortality in worldwide, and it is the top ranking cardiovascular modifiable risk factors. And astonishing is it was the top ranking in 1990, and it has maintained its top position till 2019. Inter-Aspire study was published in 2024, which was aimed to see the targets achieved by as set by the guidelines, and for secondary prevention of cardiovascular disease. And unfortunately, 61% of the patients in this study were not having adequate blood pressure control. This is another reason that every 10 mmHg rise in systolic blood pressure, there is the doubling of CVD hazard ratio. This is an interesting story of the guidelines of hypertension. It was in 1984 when JNC3 was published. The threshold for hypertension was 160 systolic and 95 diastolic, which was later changed in 1993 when JNC5 was published to 140 systolic and more than 90 diastolic. And up till now, till 2024, these guidelines and these were the thresholds which were being followed. These are the few studies which favored the more intensive control of blood pressure over less intensive control. Major CVD events were reduced with intensive control. This was with 120 versus 140 mmHg control, and this was with 130 versus less than 130 versus more than 130 control. So this was the previous guidelines in which there were 7 categories, lot of hassle and difficult to apply in the clinical scenarios. Now in 2024, ESC has categorized the blood pressure into 3 categories: non-elevated, elevated, and hypertension. So simply, if it is less than 120 by 70, it is non-elevated, and if it is more than 140 by 90, it is hypertension. In between is the elevated. There are the two categories. First and last, there is no need of calculation of the cardiovascular risk, as in first non-elevated, there is no sufficient evidence confirming the safety of BP with pharmacological treatment. In hypertension, it is on its own is a significant cardiovascular risk factor. So we are left with elevated blood pressure, where we have to calculate the cardiovascular risk. These are the guidelines that differentiate between the out of office and in office blood pressure measuring for the diagnosis of the 3 categories. As I have already said, my presentation, my talk will be more focused on what has changed. So this is the one thing that has changed is in 2018, it was out of office BP measurements, if logistically and economically feasible, was a third point. And now they have given more emphasis on, if not logistically possible, if not logistically and economically feasible, repeated office measurements should be taken. Otherwise, the gold standard for diagnosis of hypertension is out of office BP measurements. Another thing that has changed in diagnosing the hypertension is echo. Initially in 2018, the criteria for echo in patients with hypertension was ECG abnormalities, signs and symptoms of LV dysfunction. Now they have journalized it to ECG abnormalities and signs and symptoms of any cardiac disease, and you have to go for the echo. So this is almost basically the same thing. This is the protocol for blood pressure measurement in office. Patient should be seated, the validated device, cuff at the level of heart, 3 times take 2 average, obtain 2 further readings if more than 10 mmHg difference in the previous readings. Both arms can अपने लेना है and record heart rate, also check for the orthostatic hypertension for first visit. Then there was a change in coronary risk evaluation in 2018. Score system was the criteria to uh, risk stratify the patients for cardiovascular disease, and it was for the hypertensive patients, and it was not to be applied on the patients who are having already established cardiovascular disease, CKD, elevated single risk factors, or hypertensive LVH. Now they have changed it to score 2 score risk stratification score, and it is for the patients of age 40 to 69 with elevated BP, not hypertensive. So this is the one thing that has changed, and the other thing that has changed is that they have added the hypertension mediated organ damage into the category where you don't have to risk stratify the patient, you have to straight away go for the pharmacological therapy. And score 2 was introduced, which was for older people. Score 2 OP is for older people, for patients aging more than 70 years. This is basically all the same we have already talked about. So in terms of uh, uh, lifestyle modification, almost all the recommendations are the same, and are being brought forward in the same guidelines, in the guidelines of 2024, except for this one. They have all added an alternative method for uh, exercise. It is 75 minutes of vigorous intensity exercise over 3 days, complemented with moderate intensity dynamic or isometric resistance training. The other thing that is changed is in 2018 there was advice of restriction of alcohol consumption to less than 14 units in men and less than 8 for women, which in this guidelines have changed to it is recommended to avoid alcohol altogether. So another change that has occurred in the lifestyle modification is increased potassium intake, or you can say supplementation of the sodium with potassium intake. This we have already talked about. Caveats in the lifestyle modification: in uncontrolled hypertension with patients excessively high BP, you should be very cautious in prescribing the exercise, as it can be having deleterious effects. And association between potassium intake and systolic BP and CVD events may be sex specific, more stronger in women. And there is a contradiction with the CKD guidelines, which recommend a restriction of dietary sodium to less than 2.4 gram per day in advanced CKD. And the evidence for replacement of sodium with potassium was that these two trials, SASS and DECIDE SALT trials, in which sodium potassium urinary excretion ratio was resulted in reduction in systolic and diastolic BP. So blood pressure targets in 2018, it was first lower the BP to less than 140 by 90, and then you have to target it to less than 130 by 80, and the age for elderly was more than or equal to 65. Now it has changed to uh, you have to treat the patient to 120 by 129, and elderly is 85, and ongoing treatment for lower thresholds is for pre-treatment symptomatic orthostatic hypertension, age more than 85, moderate to severe frailty, that means frailty index of more than 5, and limited predicted lifespan. These are the risk modifiers which you can apply, and where you cannot risk stratify the patient with scoring system, as for young adults, in patients with score less than. So in the end, hypertension guidelines have been changed in pregnancy. इसके अंदर भी आपका 140 जो है उसको अब क्रॉनिक हाइपरटेंशन को उसको ऐड कर दिया है. So in conclusion, this is the conclusion slide. New definition add हुई है, that is office systolic BP 130 और hypertension के लिए 140. Out of office BP measurements are recommended. Risk assessments for the elevated BP, and lifestyle and pharmacological treatment for CVD risk more than 10% new lifestyle recommendation. We have already discussed potassium supplementation and implementation of the guidelines.